So today we're going to be looking at another run analysis that we did. Same sort of idea with the analysis output. This one's on our computer that we go over when you're in the lab. So the data is going to look a little bit different from our last one, but still kind of same guidelines. So at the top, you can see here we have the score. And Annie scored a 91.01% on this run. So pretty good, but still some progress that we could make. So we'll look into that further. If we look at his running category, we see that he's labeled as a collapser with contralateral pelvic drop. That's what that CPD means, with the primary factor being his right foot inclination at initial contact, and then secondary being that left foot inclination at initial contact. So we'll look into those things, but that's just kind of how we would categorize him, just looking at a brief overview after this run analysis. On the left-hand side here, we have the 3D model running in slow motion. This is what the cameras picked up as he was going through his analysis. This can be helpful as we kind of look from different planes. We can kind of see how those joints are moving and understand a little bit better where we're getting some of these numbers from. I'm going to pause that here, but we're going to go back over to this table on the right-hand side. So the next thing we see is this kind of color-coded chart, and then it assigns right side and left side. So looking at this, right side overall looks pretty good, left side's in that fair, and then we can kind of see for each joint level kind of what that is rated as based on the findings from this analysis. So definitely some stuff going on here at the ankle, kind of look at that, but as we know from the factors listed up above, there's some stuff going on with his foot inclination angle that we'll pay attention to. Okay, so looking more at general parameters. So it gives us our cadence output here, pretty good number there, 180 steps per minute. We ideally want to see it be anywhere above 165, and that's something that we pay attention to, just kind of knowing the patient's injury history and kind of thinking about performance. We want to have that number be higher. And then vertical oscillation. So this is basically how much is the runner bouncing up and down as they're moving through this. 9 centimeters, that's pretty good. I like to see it just anywhere below 10 centimeters. And then ground contact time. So we want this to ideally be less than 210 milliseconds. And you can see he's below that on both left and right leg with 204 milliseconds on the left and 193 on the right. So a little bit faster getting off that right leg than the left, but pretty comparable overall, and both are below that normative value. So that looks good. Okay, so we just talked about the general parameters there. We'll look into some of these things a little bit more as we go forward, but jumping to the initial contact. So this is when is first making contact with the ground, when that foot comes forward and first touches the ground. First thing we look at is tibial inclination. We know that this can be a really important one if a patient is overstriding, and we like to look at it to make sure that we're not putting any unnecessary forces through other joints, such as the hips or the knees. So if we look at this, we want ideally to be less than 3 degrees of flexion for this number. On his left leg, he's at 2 degrees. And then on the right, he's at 0 degrees. So both of those look pretty good. So we're not too concerned about Andy's tibial inclination. If we look down at his foot inclination, though, for this one, we want it to be ideally less than 15 degrees of dorsiflexion. So foot inclination angle is going to be like how much dorsiflexion is the foot in when it's contacting the ground? Are the toes pulled way up towards the sky, or are they kind of a little bit more parallel with the ground? So here, this is what the general parameters were kind of alerting us of earlier on that we talked about, but is about 23 degrees of dorsiflexion on the left foot when he's contacting, and about 25 on the right. So that means he's probably just in a little bit more dorsiflexion than we would ideally like. This is important to note because it has been dealing with some chronic right knee issues. And so this is something that we would take into consideration, knowing that with this high foot inclination angle, if we combine it with things like overstriding, so more of that tibial inclination angle, or poor hip control, which we'll talk about later, these things can lead to some of those runner knee sort of issues. So something that we definitely want to note here and pay attention to with Andy's run analysis. The next thing that we'll look at is strike from center of mass. So ideally we want this to be less than 29 centimeters. That's just how far in front of your center of mass is your foot landing. 29 centimeters on the right and 30 on the left. So just a touch further than we'd like on the left, but overall looks pretty good there. Okay, and then crossover here, this is an interesting one to note for Andy. Ideally, we want it to be more than 6 centimeters, but you can see it, there's a pretty big difference with the 3 centimeters of abduction on the left and then 17 centimeters on the right. So this would be something that we maybe pay attention to. Maybe it's relevant to some of what Andy's been experiencing with running and maybe not, but definitely an imbalance there with that right to left side. It's just something to take note of. And then lastly, we see that he's being categorized as a rear foot striker on both sides. So that looks good. Okay, so moving on now to the stance phase. So this is when that leg is directly underneath that center of mass, kind of when you're fully weight bearing on that leg while running. If we look at peak ankle dorsiflexion, we want it to be more than 3 degrees of dorsiflexion, and he is good with both of those marks on the left and the right. So he has plenty of dorsiflexion on the foot, so nothing that we would worry about there. If we look at pronation, this is a common one that we'll see pop up with runners and can be kind of tricky and relate to a lot of injuries. We want to pay attention here, but ideally we want less than 5 degrees of pronation with the feet. If we look at his left, he's at about 13 degrees of pronation, and on the right, he's at about 10. So both of those feet are getting quite a bit more pronation than what we would ideally like to see. So something to note there. We'll come back to this and talk a little bit about it, but sometimes it can happen if you're not getting enough dorsiflexion at the ankle, you start to compensate by rolling that foot in and getting a little bit more pronation to make up for that lack of range of motion that you have with dorsiflexion. Although we know, looking at the number above it, that Andy had plenty of dorsiflexion, so we're good there. Another thing that can lead to some overpronation is what's happening at the hips. So if your hips are collapsing in a lot, that can lead to more pronation at the foot. So we'll kind of continue. We're going to look at the hips here in a minute, and you might be able to tie that back to this pronation number. Knee flexion is going to be the next one that we'll look at. Normative values, we want it to be somewhere between 25 to 40 degrees. On the left side, he has 37 degrees of flexion, so that looks good, kind of right in the middle of those normative values. On the right, he has 30 degrees. So again, another asymmetry to note there with that right and left side. And then knowing that he has that chronic knee injury on the right, this makes sense because he's not going to be wanting to load that quad as much, because when he loads that quad a lot, he gets more stress put through that patellar tendon, and that increases some of his runner knee symptoms. So I am not surprised by seeing this number be lower on the right, but it's definitely something we want to keep note of because it'd be something that we want to address because we don't want the body compensating, trying not to load that quad for whether it's because of increase in pain symptoms or it's just a fear mechanism of him kind of getting used to not loading that quad after going through this injury. But definitely something to take note of and something that we probably want to try and increase as we work with Andy. Okay, as we get into looking at the hips during stance phase, first value here is going to be hip adduction. So that's basically how much is that femur collapsing inwards whenever you're putting weight through it. So ideally we want it to be less than 5 degrees. We don't want our knees touching each other whenever we're running. If we look at the left, he's at 11 degrees of adduction, and at the right, he's also at 11 degrees. So symmetrical side to side, but both sides are quite a bit higher than that, less than 5 that we'd like to see. So definitely some collapsing going on with both femurs. The next one we'd look at is the hip internal rotation. So how much is that femur rotating inwards? Again, less than 5 degrees of internal rotation is our ideal. We don't want those hips collapsing or rotating in. We see here on the left side, 10 degrees of internal rotation and 8 degrees on the right. So definitely some more stuff popping up here with Andy at the hips. So that would be something we definitely want to keep an eye on because we know, like we talked about with the high foot inclination, if you have a high foot inclination angle and you combine that with poor hip control, that's going to increase your risk for having more injuries at the knee specifically and showing up as that runner's knee sort of injury. The other thing we look at here with the hips is the contralateral pelvic drop. So it categorized Andy as a collapser with contralateral pelvic drop. So we know that this was something that it was picking up as an issue for him. Ideally, again, less than 5 degrees for that. Right side looks pretty good at 2 degrees. Left side's a little bit high at that 7 degrees. I like to take into consideration all 3 of these values because one might be pretty close to normative or within normative, but then the other ones are pretty high outside of it. And so that can still tell us that there's something going on at the hips. Now, if we think back to what we talked about with the foot pronation, right, we had a lot more pronation on the left side. If I go back here and look, um, yeah, here, 13 degrees on the left side of pronation, and we had 10 degrees on the right. Something I like to look at too is how much hip adduction are they getting? Because if we know that the hips are collapsing inwards, or that femur is collapsing inwards, that's going to translate down the chain and cause that foot to have more collapse inwards. So if we look at this, we know, okay, 11 degrees on the left side of adduction, that's quite a bit higher than our normative. That can explain why we have more of that ankle pronation happening as well. It's just kind of that whole leg kind of collapsing and moving more putting more weight onto the inside of that leg. And then another thing I always like to look at is this forward lean angle. Normative values are between 6 and 11 degrees. That's basically how forward flexed is your trunk when you're running. And he's at 3 degrees when we're supported on that left foot, and then 4 degrees on the right. So both are a little bit low. This is something I'd look at more if we were worried about a lot of overstriding. By getting your trunk a little bit more over, you can get your feet a little bit more underneath you. And that would be something I'd pay attention to also as we're thinking about the performance side of things. And then at terminal stance, so this is going to be when that leg is as far back behind you before you push off. Big thing we look at here is hip extension. Our normative values are 10 to 19 degrees, and Andy looks good here with 13 degrees on the left and 14 degrees on the right. That's something that I see a lot of runners struggle with, is that hip extension. And like we talked about in the last video, it can be a couple of things. It could be like not having strong enough glutes, not using your glutes when you run, or it could be tight hip flexors. But that looks pretty good here from Andy's report, so I'm happy with those numbers. And then ankle supination. So we want that ankle to supinate a little bit when you're going to push off. On the left side, he's still stuck here in a bit of pronation. So again, that kind of ties back to we're in that pretty excessive pronation throughout the stance phase, and that correlates into this terminal stance. And then lastly is our swing phase, and this just looks at hip flexion, but Andy looks pretty good here with getting more than 10 degrees on both the right and left side. So nothing that I'd be concerned about here. In terms of his swing, that looks good. But big things here with Andy that I'd be focusing on is what's happening at those hips, focusing on correcting some of that collapsing that's happening at the hips, and then thinking about some of the pronation that's going on, and then that foot inclination angle. So these would be things that I'd be cueing with, trying to get your trunk leaning more forward to try and make sure that your feet are landing underneath you, or focusing just on like taking a little bit quicker steps. He has a good cadence, like we talked about. He's at that 180, but if we can get that even a little bit higher, he'd be less likely to be getting that foot out in front of him as much as he is, and likely decreasing that foot inclination angle. So in addition to those cues, I would also be having him work on some strength at the ankle, but then also further up the chain at the hips to just help prevent some of that collapsing that's going on. One more thing that I like to look at here, that we can see well on this computer, if I pull up the graphs that are at the bottom here, this is a nice way to just kind of compare data. And so what I've done is look at hip angles. And I've only selected the internal and external rotation at the right and left hip. This is an easy way to kind of highlight. So this is our right hip internal and external rotation graph. You can kind of see those dips going in and out. And then the left is in that orange. Something that I notice here is that those left dips going down into the internal, so the ones that are dipping down, kind of end up going a little bit further than compared to the right side. So that's just something that I'm looking at and saying, oh, there's probably some asymmetry there between right and left sides. And we can kind of see that visually from this graph. And then taking that information from the graph, we can go back to comparing it with that 10 degrees of internal rotation at the left and 8 degrees of internal rotation at the right. So just another way to look at the data and visualize it a little bit easier.
Also looks like with that you can look at it over a bit more of a period of time, whereas the data that you get, that you just explained, is kind of like the cumulative of all of the analyses. But this is like, okay, frame by frame, step by step, we can kind of see, you know, are there really obvious points, or is it consistently just like that left doesn't go as far or go further. So that's also very nice that you can really hone it in a little bit more specifically than just whatever the data gives you from a summary perspective.
Right. Yeah. So, like, say if I had started the runner, just run normally, and then partway through we did some cueing, and they were still running, or they switched their gait, then we might see that transition a little bit further in on that graph. So, yeah, kind of a good way to look at, is this a consistent thing, or is this something that they started running, and then as they get warmed up, it starts to change.
Perfect. And you kind of touched on this, but maybe just good to summarize it. So, Andy came in for a run analysis because he had been having a previous history of a right knee issue, a patellar issue. And, he's kind of returning to run. He's back in his full program, but he wants to make sure that all of his issues aren't going to lead to more issues down the line. So, what would you say? And I think, like you said, you did touch on this, but what would you say are like the big couple of things that you're looking at to be like, okay, this is definitely something we need to watch out for him so that his knee pain doesn't persist or get worse or recur?
Mm-hmm. Yeah, so I think the biggest thing is, again, if we go back up and look at just how it categorizes him, because this is just going to kind of highlight and point us to directly, like, what are the biggest things that we need to pay attention to. We know he's a collapser, so there's something going on at the hips. We definitely want to pay attention there. And then for both the primary and secondary factors here contributing to his score, being those foot inclination angles on both sides, and we can kind of see here ankles being listed in that poor category. That's whenever I look at, okay, there's stuff going on at the hips, and we know that poor hip control combined with that high foot inclination angle is going to put excessive stress and force on different parts of the body, specifically that knee. Those are going to be things that I'm like, okay, we need to note this to make sure that we address these issues so that long term, moving forward, we don't have a re-injury of that right patellar tendon.
Perfect. Yeah, that sounds like something you would, on follow-up gait analyses, you would be reviewing and making sure that those changes are actually happening, not, just he says they are in that regard.
Yep, absolutely. Yeah, we'd want to be looking at all of those numbers, and then also paying attention to how this score number is improving as well, to tell us that we're landing more within those normative values as we make progress.
Perfect. Okay, so after hearing all this, like, this is obviously amazing. Like, there's so much information that we're getting here. But my question is, like, really, what is the difference between coming to you, getting this 3D analysis versus, getting maybe one of those AI tools, or just filming myself at home and kind of drawing lines on myself and getting that information? Like, what really is the difference between 2D and 3D?
Yeah, there's a lot of tools out there at this point that you can use, like, on your own, that make it really easy to just like film a video of yourself running on the treadmill, look at a couple different angles, and it will measure some of those values for you. The difficult part is that a lot of the cameras don't shoot at the frames per second that you need to truly get each individual phase of running. So, for example, like initial contact, when that heel first touches the ground, when you're looking at a phone, it's going to be kind of a bigger jump between those frames. So you might not have the exact moment of when your heel's actually touching the ground, which then can give you some skewed data as to whether you're really overstriding or not, or by how much. The other thing is too, is that you're not going to get some of these values. Like, if we look back at like the pronation, right? That was a huge thing, and something that we noted that we really want to pay attention to. You're not going to get that from a 2D analysis looking at either just the side or the back, because that pronation happens in that transverse plane. So it's going to be a plane that's only picked up by a 3D visual.
Interesting. So it sounds like maybe frontal and sagittal, we can kind of get, let's say, relatively decent data, but to your point, we move in 3D, our body rotates quite a bit with running naturally, and that's normal, but we can't really visualize that. And then that rotation, if not picked up on or addressed, we could fix all the frontal and sagittal plane stuff we want, but it won't actually matter if we're not getting that full picture then that we get with this.
Yeah, exactly. And again, like, not just the pronation, but also looking at that hip intra-rotation. That was something that we noted was a huge factor here in Andy's analysis. That's going to be another movement that we won't see unless we're looking at a transverse plane. So maybe we fix some of the things like foot inclination angle and get that a little bit better. But if your hips are still collapsing, they're still rotating, then you're not going to be fixing the problem that's further up the chain. The other thing too is that, like, we work on a lot of the cueing here in clinic. And so it's nice to have someone to be able to talk you through like what this data means, how do we address it, how do we change it, and then try to make some in-person, like, on the spot changes so that you leave feeling good about what you're doing when you're going home, rather than just trying to guess at how you fix some of these things.
So it sounds like precision. We're getting more of that precision on site in the appointment, and like you said, it's less. While there is some trial and error, it's not in the same way as you just going home and hoping for the best. It's more based on all of this data and all of the things you've seen and have been able to interpret with your expertise. The patient is getting a very comprehensive idea of like what they need to work on, and then the follow-ups we can really address how much better has this gotten, if it has or hasn't, why is that the case, and how do we proceed forward.
Yeah, a lot more comprehensive without any of the guesswork.
Perfect. Okay, well, this was really great. It's really good just to see, like, you know, as a patient, what you're getting in the session. We get to look at, like you said, the 3D actual analysis on the treadmill. We get to see all of the various joint scores and then the very specific details, and then even further into the like frame by frame, step by step on those graphs. And then obviously just having you being the expert in this, explain all of that and put it all together for us with drills and strength and any of the rehab necessary to either prevent injury or improve performance or rehab from a current injury to make sure that we're returning to the best form of gait we can have. So yeah, it seems really comprehensive. It's really great. And you know, Dr. Emily is still taking new patients for this. And if you've been ever wondering, like don't hesitate. You know, the sooner you get this looked at, the better you'll be, and the less time you'll spend wondering if injuries are going to come.